Bismillahirrahmanirrahim. Let's see the ectopic pregnancy. Ectopic pregnancy means when the fertilized egg is not implanted on the normal site. What is the normal site? The lining of uterus or the endometrium. So this is normal location. So normally you see in the, here is the ova, it is fertilized and then it travel by cleavage pathway and undergo marula stage and then blastocyst, and which implant at the day 8 to 9 at the endometrium. Okay, so this is normal. If it's not implant on this side, mean if it implant in the fallopian tube, which is more than 95% ectopic pregnancy cases. So you can see here implanted here. Most common in the is the fallopian tube, and in the fallopian tube most common site is ampulla, which is 70%, and then you see the isthmus or fimbriae and the interstitial. So there are other locations, but more than 95% cases the ectopic pregnancy you will see in the fallopian tube. Other sites are like ovary, so and if there is in the cervix, or if there is any cesarean section occur, so it can implant, and sometimes it can implant in the abdomen. Okay, so these are different sites of the ectopic pregnancy. Okay, so what is the ectopic pregnancy? Pregnancy outside the normal lining of the uterine cavity. So incidence is 1.5%. So what are the sites of ectopic pregnancy? You know better. So there is more than 95% is the tubal, and the other are the ovary, cervix, abdomen. C-sections occur are the rudimentary horn. Rudimentary horn, it's a remnant of the developmental tissue, for example, the uterus or the uterus, cervix, any component. So where this zygote can implant. So sometimes you will see the heterotopic pregnancy. Heterotopic mean one is on the pregnancy is on the normal side, mean on the in the endometrium. So other is at the abnormal, mean one is ectopic, one is a normal pregnancy. So this is known as heterotopic pregnancy. What is the presentation? Presentation is pain. Other symptoms are considerable. For example, mild vaginal bleeding, it may occur. So sometimes there is a shock condition or the syncope attack due to rupture of the ectopic pregnancy. So these are sometimes, but the main complaint is always the pain. Okay, lower abdominal pain. And if you see in the general, you may see or not in the sign is the shock, or if you look at the abdomen. So when you put your finger over the tubal area, so what you will see? Tenderness. It's a colon, or sometimes you will see the colon sign if there are lungs tending. The interpartum hemorrhage. What is colon sign? Colon sign, this is the bluish discoloration around the umbilicus. Okay, so this is one of the sign of the ectopic pregnancy. In the pelvic examination, what you will see, because it's already complaint of pain, and when you undergo this cervical motion, so this causes the tenderness. So sometimes it's too severe, the patient may jump. So jumping sign, or you can say frog like sign, so they jump like a frog. Okay, so cervical motion tenderness, it's too severe. Okay, and you may see the nasal fullness. Okay, or uterine is bulky. So these are the sign of the ectopic pregnancy. Okay, and in the etiology, what you will see, the main etiology is the abnormality in the tube, either the structure or in the functional. Okay, so due to inflammation or adhesion, the infection in the pelvis, for example, the pelvic inflammatory disease, so you will see the inflammation and adhesion of the uterus, so which is a risk for the ectopic pregnancy. Other are if someone is taking the progesterone only contraceptive or the intrauterine device, so this increase the risk of the ectopic pregnancy. And are smoking, the increased age, the older age, and the history of ectopic pregnancy or the history of tubal surgery. So these all lead to increase the risk of the ectopic pregnancy. What are outcomes of the ectopic pregnancy? So there are some site related, and there are some uterine related. For example, in the most of the case it's tubal. So what you will see, you see the distension. So because of ectopic pregnancy, and sometimes it may abort, mean it's abort from here, and it may most of the time you will see if it's aborted, you will find their component in the abdomen or in the peritoneum, or sometime it may come, but rarely it come to the uterus. Okay, so sometimes the tubal may rupture due to the size of the this ectopic pregnancy and intrapartum hemorrhage. So these are the most complication, or you can say outcomes of the ectopic pregnancy. And in the uterine, what you see in the uterine, you see only decidua because of the hormonal changes. Okay, ectopic pregnancy, although here, but there are some changes over the uterus. So what you will see, you see only decidua, but there is absence of villi, no villi, only decidua. Okay, and this condition may lead to what? Erisia satella reaction, mean when there is the growth of the endometrium, hyperplasia, so there are changing in the endometrium, so there are glandular changes, hyperchromosomia, so these are different changes occurring, so this is known as the Erisia satella reaction. In this picture, what you can appreciate, the aborted tube. Okay, and this picture you can again see the tube is the aborted, and here you can see the also you can see the rupture of the fallopian tube, and here is the laparoscopic view where you can see here is the ectopic pregnancy component, here is the hemorrhage due to rupture. Okay, so this is the tubal rupture you can see, and this is here is the case of the extraperitoneal rupture. Okay, so this is one of the complication in the ectopic pregnancy. What are differential diagnosis? You can think of all the etiology of the acute abdomen or bleeding in the early pregnancy. For example, in the acute abdomen, you will see the appendix, or you can see any malignancy or PCO, all other symptom endometriosis. So whatever they cause the acute abdomen, so these are differential diagnosis of the ectopic pregnancy. What investigation you do? Investigation, you go for the ultrasound to find your diagnosis. Okay, so what you see the empty uterus. The uterus is empty and there is adnexal fullness. So adnexal fullness, when you can appreciate this, when the beta hCG level is more than the discrimination zone. What is discrimination zone? You see the when the beta hCG is more than 1500, so you can appreciate via the transvaginal sonography, or you can say ultrasound. Okay, when the beta hCG level is more than 3500, so then you can appreciate via the abdominal sonography. Okay, so here you can see the transabdominal ultrasound. Okay, and here you find the ectopic pregnancy, and here you see the transvaginal the ultrasound. Okay, and here you can appreciate the ectopic pregnancy. What are the other investigations? You can check by beta hCG. Normally, what is happening? There is increase in the beta hCG. It's almost double during 48 hours in the normal pregnancy. But in this case, you do not see the increase is more than the 60%. So if it's less than 60% increase in beta hCG after 48 hours, mean it's a case. It suggests the ectopic pregnancy. And you go for the laparoscopy, and laparoscopy can confirm your diagnosis. Okay, and most of the time we start that the laparoscopic treatment to for the ectopic pregnancy when there is a patient present with the shock and he is hemodynamically unstable patient. So you cannot wait for the other investigation. So you enter into the laparoscopic treatment. Okay. Here you can see the laparoscopy where you see that here you can appreciate the tubal pregnancy. Okay, here you also can see the right ectopic pregnancy. Okay, here is uterus, but the pregnancy is here. In the treatment, the first measure is the anti-shock measure. Mean you should stable the patient. You give the IV fluid or anything to maintain their balance. So if IV fluid or the blood, whatever you needed, you can go for. So prevent from the shock. If the patient is stable, then you go for the conservative treatment. Means you give the expectant. So it may lead to the abortion. Okay, so this is the first measure. So if it's not work, then you go for the medical. What is the medical treatment? Medical is a methotrexate. So we give the 1 mg per kg, but the body weight IM. We give the first dose. So, but there are some indication and contraindication. You first confirm them, then you can give. What are indication and contraindication of this? What are indication and contraindication of this drug? So patient should be vitally stable, okay, and the ectopic pregnancy is not disturbed, means it's not ruptured, and the size should be less than 3 centimeter. Beta HCG level should be less than 6,000, okay, and there is no fetal pulse, and she is not breastfeeding, and she is not immunity compromised, okay, and there is no sign of infection, or there is no liver, kidney or blood disorder, okay. So if these conditions are fulfilled, then you go for the methotrexate, okay. But after that, what you follow up by the beta hcg. Look for the beta hcg, especially day 4, day 7. What do you want to see at day 4 and day 7? What you want to see at day 4 and day 7? You want to see there is decrease in beta hcg or not. The beta hcg decrease should be more than 15%, okay. If it's not decreasing, mean it's not working, okay. So and continue your follow up until the beta hcg level become 0, okay. If it's become 0, means your medical treatment has been successful. If the medical is failed, you go for the surgical process. In the surgical process, you see the patient is stable or not. If it's stable, you go via the laparoscopic approach, where you want to remove the pregnancy, mean salpingostomy, or you cut the fallopian tube. So it's when only we remove the pregnant component if we know the relative side is also damaged. So and but the patient want to conceive in later life, okay, then you try to just remove the component and try to preserve the fallopian tube for the next pregnancy, okay. So and if it's not possible, then you of course cut the fallopian tube. And if the patient is unstable, then you simply go with the open laparotomy, okay. So and also give the anti-D immunoglobulin 50 microgram if the patient is Rh negative. So it's a prophylaxis, okay, to prevent for the upcoming the pregnancy. So if it's Rh negative, you of course give the anti-D immunoglobulin 50 microgram, okay. Here you can see the salpingotomy, where you simply give a small incision and to remove the fetal component, okay. And in this case, you cut the tube, okay. So this is salpingectomy. This is salpingotomy. How we approach the ectopic pregnancy when someone is present with the early pregnancy with pain and bleeding. So this is all about the ectopic pregnancy. Thank you very much. Allah Hafiz.